Good morning to everybody. Thank you very much again for this kind invitation. The task of today is very difficult for me because effectively we don't have any IBM about this topic. So during these days before this Congress, I try to find as much as possible patients with this kind of problem, acute and chronic messy rotator cuff tears. For example, this was a tennis player of 88 years old that plays in my club, and unfortunately he fallen down and hit the shoulder, and he had a an acute and chronic tear, as you can see here. And I suggest him to go for physical therapy to go on playing tennis in his life, of course. Second, if you can see here, he was a 67 years old active man with an unbalanced shoulder with a mild fatty infiltration of the muscle, as you can see here. And I suggest him to perform a reverse shoulder arthroplasty. The third one that I would like to show you is an active man with a full thickness rotator cuff tear of the dominant arm. He's 52 years old, and in this case, I suggest him the repair, of course, because our goal is to find in arthroscopy a tendon like this, mobile and full of vessel, in order to get as much as possible the healing of this rotator cuff repair. So, should we treat an acute and chronic massive rotator cuff tears? Unfortunately, we have no evidence. Some authors believe that traumatic tears occur mostly in diseased or aged tendons, of course. But only one paper thoroughly discusses this topic, as you can see here, this one. So, how to detect an acute and chronic tear? We have preoperative symptoms and signs, like definite history of trauma within 6 months. Because of the trauma, the patient lost severe function of the shoulder in the most of the time, some sign of the degeneration of the cuff, and full thickness rotator cuff tear on MRI. But above all, the patient has an history of previous pain in the same shoulder and in the opposite one. These are MRI findings that we had to check before the operation, before a surgical procedure, like edema in supraspinosus tendon and infraspinatus tendon, and less atrophy and less tangent sign than in chronic tears. Is present a kinking sign, after I will show you in this slide, that is one of the two most important MRI signs that we have to check for an acute and chronic diagnosis on MRI, edema and kinking sign that have both a high specificity, as you can see here. So, what about IBM? We have no IBM. So, to answer to the task of the presentation, I divided the two groups, the acute and the chronic group, of course. And I include in the first group patient presentation after 1 month, and I include in the second group, or chronic group, a patient presentation of 1 year. So what about the presentation after 3 months? Is an acute or a chronic presentation or a chronic tear? I have had an idea. I found this paper in the literature that shows that an acute rotator cuff tear is defined as an acute symptoms for less than 4 months after trauma with a full thickness supraspinatus tear. And moreover, there are no difference in clinical outcome after rotator cuff repair performed within or later than 3 months after trauma. So I decided to include in the first group of acute tear the 3-month presentation. What is an acute clinical presentation? Usually the patient has a persisting rotator cuff tear, as you can see here, and the trauma worsens these symptoms. And these are the arthroscopic findings: smooth chronic tear margin, smooth greater tuberosity, hematoma, acute extension of an existing chronic tear, as you can see here, And what about the treatment? We can choose for conservative treatment, rest, drugs, rehabilitation program. We have just talked about that a lot today. But we have to think always that patients younger than 50 years old with acute rotator cuff tears should undergo early operative fixation, especially because they have a typical involvement of 2 or more tendons in 50% of cases and subscapularis tendon, moreover. And patients with multiple tendons torn were more likely to fail conservative management. The retear rate is low in patients aged less than 50 years, so it's better to treat them. And I would like to show you this risk stratification, according to Kinner, of non-operative treatment can be really very useful. As you can see here, we have a group 1, or low risk of progression of the tear, where is included a full thickness tear, small, less than 10-15 millimeter, with cable intact, and irreparable tear. The second group include a higher risk full thickness tear, more than 15 millimeter, as you can see here, with anterior cable involvement. And the third one include, of course, people with pseudoparalysis, external rotation lack signs. But acute and chronic, as you can see in this table, will heal if you treat surgically. And the results are better than in the chronic repair. So what about chronic, the presentation after 1 year? Of course, we have to take into consideration prognostic factors, as you can see here, and above all, the size and the location of the tear, because for the supraspinatus, it's very important the cable disruption, and for the infraspinatus, the width of the tear, more than 15-20 millimeters, are at risk of muscle degeneration. And the risk of tear enlargement, in this case in chronic tear, were 22% and 50%, as you can see here, after 2 and 5 years respectively. There was a correlation between the existence of considerable pain and a clinical significant increase in tear size, but we have a countdown, I have to say that, because we have a time to degeneration. As you can see here, 2 years for supraspinatus and 3.1 years for infraspinatus. And tear enlargement is correlated with the development or progression of fatty muscle infiltration. Unfortunately, 60% at 5 years enlarge and worsen. Risk factors for progression are tear enlargement, larger baseline size, anterior cable disruption, tear enlargement of 1 centimeter or greater, and above all, pain. 59% experience functional improvement with conservative treatment, as you can see here. But what matters most for me to choose the right treatment? Above all, the clinical evaluation and radiological evaluation, because I need to have a functional shoulder. If you don't have a functional shoulder, it's impossible to go for sometimes to go for conservative treatment with a rotator cuff tear. What about radiological signs? It's very important, the proximal humeral migration. You need only an X-ray to understand that this infraspinatus doesn't work in this case, and I trust a lot in the tangent sign that you all know. What can be the possible treatment in case of massive irreparable cuff tear? All we know this surgical procedure, of course. If you don't have osteoarthritis, we can recur to lat dorsi transfer or superior capsular reconstruction. Otherwise, we perform RSA or RSA plus lat dorsi transfer. So some take-home messages to resume all these news. I would like to remind that acute and chronic rotator cuff tears have similar symptoms as in acute traumatic rotator cuff tears and may be triggered by trauma. Acute and chronic rotator cuff tears progression is similar to chronic rotator cuff tears, it is essential to discriminate between functional and non-functional shoulder. Early surgical reconstruction is recommended in patients younger than 50 years of age. After acute and chronic rotator cuff repair, the clinical scores and range of motion recovery is better than the result of chronic rotator cuff repair. And surgical options for patients with non-functional shoulders, for me, are RSA, lat dorsi transfer, and RSA plus lat dorsi transfer. Thank you.